Our next presentation, Christopher Ryan and Catalin Gheorghiu from the Strategic Research and Evaluation Unit at the Department of Health. And this is the Department of Health view, using the data to identify avoidable hospitalisations. And I think there's a lot of interest in this. So, Catalin, are you going first?
No.
No, Christopher is.
All right, I'm connected. Yep, there we go.
Working? Okay, looks good.
Yep. Take it away, Chris.
Yeah. So, great conference so far, really interesting presentations. I'm Christopher Ryan. This is my friend and colleague, Catalin. We're delighted to be here to talk to you about our latest use of ABF data, which is kind of on the avoidable and same-day inpatient hospitalisation space. So a little bit about who we are and what we do. We're in the Strategic Research and Evaluation Unit. That's staffed by members of the Irish Government Economic and Evaluation Service. So this was, as you may know, a cross-departmental service that was set up in 2012 after the Great Crash to try and improve the use of data and evidence in policy making. So why are we doing that? Well, we also kind of work on an internal consultancy basis within the Department of Health. So we kind of try and make progress on big ticket items for the department. And why are we interested in this space in particular? Well, the first reason is capacity and efficiency, as kind of the Secretary General alluded to. We know that we're operating in a constrained system that has occupancy of over 85% kind of routinely. We also know that long-term demand, and we've got an ESRI capacity review, which is going to be published at the end of the month. We know that demand out to 2040 is going to continue to grow on the back of an ageing and growing population. So in order to kind of close that gap between what we have and what we need, we need to be as productive as possible. And then we're also interested in it because of the Sláinte Care goal of integration of care, treating a person at the right place at the right time. And we think that the avoidable hospitalizations really cast a lens onto kind of progress towards achieving that goal, because if an individual can be treated closer to home at a lower acuity setting, that's good for both the individual but also for the system as a whole. I should just say who we are not, which is clinicians. So we have consulted widely within the department with some of our clinical colleagues. We've now started consulting more broadly with the HSE, and we'll be meeting kind of various people over the next month. But we're quite open to feedback, and we don't have any kind of a priori assumptions in this regard. Mm-hmm. So just a few kind of terms that we're going to be going into. The first one is probably a bit easier. It's same-day inpatient hospitalizations. They occur when a case is admitted to as an inpatient but discharged the same day. They accounted for about 22% of all inpatient cases in 2024, so a significant volume. And we just think that it's worth exploring whether some of these cases could be treated in a lower acuity setting. Then the slightly more difficult or trickier term is around the avoidable hospitalizations. These are called ambulatory care sensitive hospitalizations in the literature. Their underlying diagnosis was flagged by clinician panels as a complication that could have been avoided through preventative care and early disease management delivered in a primary care setting. They accounted for 15% of all bed days used in acute hospitals in 2024, and they're split across the sort of 19 conditions that you see on the right panel. The case counts in there reflect 6 years from 2019 to 2024, and looking at these allow us to target policy interventions where they're needed most. And of course, we're only able to do this analysis because of all the ABF data that's collected at a hospital level and through the HSE to us. So that's it from the front of house stuff. I'll now hand over to Catalin, who's been actually crunching the numbers, and will take you through the more technical aspects of the presentation.
Great, thanks, Christopher.
All right, hi everyone. I'm really glad to be here. The clock is ticking, so let's get right to it. We connected 3 datasets to form the base of the analysis. The pivotal piece, hospital inpatient inquiry dataset, our good friend HYPE, 2019 through 2024, containing core information for every acute episode of care, right? We're talking hospital, treatment regime, admission pathway, the length of stay, up to 30 diagnoses coded through the International Classification of Diseases, the diagnosis-related group, the DRG you've seen all day, and some patient demographics. trove of information. We carried out a literature review to come up with the second data set, a list of avoidable conditions connected to HYPE through the primary diagnosis ICD-10 Australia notification code. The definitive list of avoidables comes from the Atlas of Avoidable Hospitalizations, prepared by Antia Page in 2007, on the ICD-10-AM framework HYPE also uses. It crucially contains exclusions from the ACS status based on comorbidities and procedures administered to the patient, which we can thankfully account for thanks to, once again, the trove and treasure that is HYPE. Finally, we used the diagnosis-related group to link HYPE to the third dataset, the activity-based funding most recent price list. It contains the parameters necessary to compute the required funding for every episode of care. Every DRG has separate base prices for day case and inpatient hospitalizations. They are computed from expenditure information collected from a subset of hospitals, and inpatient prices are then adjusted further based on the individual case's length of stay, right? Just as a refresher so that we're all on the same page with what's happening here. To give you a high-level view of the analysis, we focused on 6 core metrics for both avoidable and same-day inpatient hospitalizations. We're talking case count, total activity-based funding required, average episode level, ABF required, total bed days, average episode length of stay, and comorbidity incidence. These were computed yearly from 2019 to 2024, as well as aggregated over the hour of admission and the age bracket. We disaggregated the national results to observe regional and hospital-level variation, and we further drilled into the clinical layers to observe how the core metrics vary across major diagnostic categories, think endocrine conditions, diagnosis-related groups like diabetes, and finally, diagnoses themselves, such as type 2 diabetes with retinopathy complications. All of this is bound together in one big dashboard to inform decision makers at different levels. The users, perhaps some of you even, hopefully, can then focus on what interests them and control the granularity of results while doing so. Now, let's take a look at some of the tricks we taught the dashboard. I tell you about ACS hospitalizations. What is your first question? Well, it's probably, what are those? But we went over that already. Your second question is probably, how many are there? 80,000 in 2024, 92% of which were unscheduled. These admissions through the emergency department are what the big green bars show in the graph over here for those who can't see. 12% of all inpatient hospitalizations are ACS, as shown by the gold line, which is an increase in the proportion of total inpatient cases over time, right? Not just in the number of hospitalizations compared to 2019. Another question might be, all right, but how many ACS hospitalizations are there in my hospital? This is the sort of thing the slicers on the right side are for, the granularity control that I mentioned. You can get the information on case counts for any given combination of ACS and STI status, hospital admission pathway, and diagnostic category. If we have time, we'll illustrate this capability with a quick demo of the dashboard at the end.
We don't have time?
No quick demo of the dashboard at the end. I'm glad that was settled. I know what to expect. Now, what does it take to deal with all of these ACS cases? We focus on the dominating ED admission pathway in these panels here and see the evolution of required ABF on the left and the evolution of required bed days on the right for ACS care 2019 through 2024. You can see both measures have been creeping back up after COVID, both in terms of absolute value and in terms of proportion of the acute care required ABF and bed days. In 2024, 400 million euro was the approximate financial resource requirement, and 400,000 bed days was the approximate capital requirement. We can go further and demystify the idea of ACS conditions a little bit, looking at actual individual diagnoses as coded by the International Classification of Diseases. Now, this is crucial for the policy interventions with the greatest expected returns. And the data shows us that it's COPD with lower respiratory infections, congenital heart failure, and COPD with acute exacerbations that we see the most often in top to bottom order of the lines you see in the figure. COPD stands out. The single diagnosis with respiratory infections is as prevalent as the next two combined. This is where we must intervene with both new and existing tools. More about that in a couple of slides. Before that, to wrap up the overview of ACS hospitalizations, we must acknowledge the potential of this analysis for identifying intervention opportunities and transferable good practices across health regions and hospitals. Right? So, for example, this slide shows the average length of stay for ACS cases across regions on the left, and the proportion of acute bed days used by ACS cases across regions on the right. Every region has its own bar in every year, so not only can we compare regions at a point in time, but we can also see how the comparison shifts over the years. We see on the left side that the Midwest, light blue, low bar, fourth from the left, is below the horizontal ALOS line every single year. And yet on the right side, it stands out in terms of how many of its bed days are used by ACS cases. The West and Northwest region, on the other hand, has similarly low ALOS. It's the yellow bar. But it also has the lowest share of bed days used by ACS hospitalizations. So perhaps there is knowledge or technique to be shared, or perhaps this is an opportunity to adapt delivery in the Midwest for the unique challenges it's facing. This is the sort of outcome we might get from interrogating this dashboard. We won't run through the same-day inpatient analysis in the same level of detail, even though we could.
Sorry.
No, all ACS analysis was replicated for same-day inpatient cases, the whole 9 yards. Now, we should discuss the key points, though, namely that there are almost double the cases we saw with ACS, and 4 out of 5 are admitted through the ED, but, and this is a big however right here, 63% of the 120,000 same-day inpatient hospitalizations coming through the ED never make it to an inpatient ward, thanks to the medical assessment units and surgical assessment units attached to acute hospitals. This leaves around 43,000 same-day inpatient cases in inpatient wards that we need to worry about, occupying 22,000 bed days and requiring 36 million euro in activity-based funding. There are 2 main takeaways from this analysis. Number 1, the case profile in the inpatient wards does not look very different from what's captured by MAUs and SAUs. Chest pains and frailty-related issues like syncope and collapse or other musculoskeletal treatments dominate both sides of the coin. We wonder then if it's possible to build further on the success of MAUs and SAUs, squeezing this last third of same-day inpatient cases out of the inpatient wards. And the second takeaway, much like with ACS hospitalizations, there is notable interregional variation in terms of same-day inpatient incidence. We saw, for instance, a significantly larger share of SDI hospitalizations outside MAUs or SAUs in the West and Northwest region, and some other regions see their SDI incidence going up relative to their own populations, while others see it going down. If there's an opportunity to reduce this variation, we should pursue whatever means at hand for the sake of a nationally equitable service, be it identifying relative underperformance for remedial interventions or transferring a good practice. So we've done the analysis. Sorry if some of you feel as tired as if you had also done the analysis yourself by this point. But the analysis is done, okay? What happens next, what material change on something like ACS and SDI hospitalizations can the ABF data lead to is the question we're left with. We of course intend to continue monitoring the hospitalization rates, perhaps as an indicator of how well the shift left of care is going, but it's also important to tie up the loose ends. Number 1, analyzing a sample of actual clinical cases could tell us what alternative care pathways already exist for people and when. Number 2, focusing on COPD and probing the effectiveness of interventions designed to keep it in the community, such as the chronic disease management program and COPD virtual wards, would help reduce the largest category of ACS admissions And number 3, reviewing admission policy for observation and diagnostics in cases of benign symptoms in scary areas where things can quickly escalate, like the chest pains, could be the first port of call in reducing STI hospitalizations. And with the dashboard demonstration skipped in the interest of time, all that's left is to thank you for your attention.
Thank you very